Hello, and welcome back to The Critique.
Great to be here.
This session is based on the very insightful review by Dr. Reza Lankarani. He's a general surgeon, the founder of the Surgical Pioneering newsletter and podcast series, and an editorial board member of the Genesis Journal of Surgery and Medicine.
A really sharp analysis.
It is. So we're looking at a retrospective cohort study on adolescents after sleeve gastrectomy. It tracks weight, GLP-1, and GIP over 5 years and tests semaglutide for those who regain weight.
This is fantastic work. I mean, getting 5-year follow-up data on 264 adolescents is, well, it's just incredibly valuable.
Absolutely. And the semaglutide findings are genuinely exciting. But we're here to make it even stronger, to really maximize its impact.
Right, because even great papers can be elevated. The data here is so strong, especially the hormonal tracking. It really sets the study apart.
It does. And it makes a strong case, just descriptively, that the weight regain group shows earlier hormonal attenuation.
They note that the GLP-1 and GIP levels were significantly lower at year 3 in that WR group. So naturally, they start to hypothesize that this could be, a predictive marker.
And that's exactly where we need to focus our first critique. You have this powerful idea, but does the statistical framework actually support it as a prediction?
Precisely. The central claims about the predictive role of these hormones, they need formal statistical validation that right now is being withheld for just descriptive comparisons.
Which, to be fair, they are upfront about.
They are, and that's commendable. The limitations section says clearly the study wasn't powered to find these correlations and that they didn't run, say, a Pearson or Spearman analysis.
So the big risk here is concluding that these hormonal patterns may be linked to weight regain risk.
Yes, it's a bit of a logical leap because you're just looking at group averages over time. It risks overstating what is essentially a temporal observation. It's exploratory.
Not a confirmed correlation.
Exactly. And that ambiguity could weaken the paper's final impact, especially if the goal is to drive future screening protocols.
So the suggestion?
Well, it's about strengthening that foundation. You either need to reframe the conclusion to really match the stats you've used, or you could perform a more rigorous exploratory analysis to actually support that exciting hypothesis.
Okay, so reframing seems like the simpler path. But what would a more robust test look like with the existing data?
It's about being creative with the analysis. So, for a concrete example, let's start with just reframing the language. In the discussion, in the abstract, instead of linked or suggest correlation, you just reiterate that these are temporal observations.
So framing it as hypothesis generating.
Exactly. Or, if they really want to push the predictive angle, we'd suggest some specific hypothesis testing. They could take their existing data and put it into an exploratory survival analysis.
Like a Cox proportional hazards model?
A Cox model would be perfect here. You define the outcome not just as weight regain, but as the time to clinically significant weight regain.
Maybe a 10% gain from their lowest weight.
Right. And then you use the hormonal data at the rate of GLP-1 or GIP decline in the first couple of years as your variable.
Ah, so you're not just comparing means anymore.
No, you're assessing if a faster rate of hormonal decline actually increases the risk of hitting that 10% regain threshold sooner. That gives you a much stronger statistical backbone for talking about predictive utility.
That's a huge shift. It moves from a static snapshot to a dynamic time-to-event analysis. Very powerful.
It really is.
Okay, let's pivot a bit to the cohort itself. Adolescents are complex. It's not just about physiology.
Not at all.
And the paper does highlight a key anatomical finding. The gastric volume in the weight regain patients increased a lot, reaching over 220 milliliters by year 5.
Yes, and they link that to increased food intake. But this is where the paper needs to widen its lens.
Right.
To get a truly holistic picture of weight regain in adolescents, the analysis has to bring in the behavioral and psychological factors that they acknowledge are critical, but ultimately exclude from the analysis itself.
The paper says it all, really. It identifies developmental, behavioral, and hormonal factors as key influencers.
It does, but then in the limitations, it confirms that things like dietary adherence, physical activity, mental health, none of that data was included.
And that leaves this huge explanatory gap.
A massive one. That larger gastric pouch, it doesn't just expand on its own. It only becomes a problem if the patient is actually using that extra volume.
Which is driven by behavior, by psychology, by loss of satiety.
Exactly. And if you exclude those known drivers, you can't really assign the proper weight to hormones versus the more mechanical or behavioral causes of the regain. It's a critical piece of context that's missing.
So given they have this incredible 90% patient retention rate, how can they bring that context back in?
That's the key. The retention is so good, so our suggestion is twofold. First, you can use that retention to retrospectively strengthen the discussion around these factors, and second, you can beef up the physiological side with known counter-regulatory signals.
Okay, give me a concrete example.
Let's start with what they do have, the anatomy. We'd suggest some mechanical modeling in the discussion. Dedicate a specific section to modeling that increased gastric volume, 222 ml versus 192 ml, as the primary anatomical mechanism for regain.
Establish it as the physical prerequisite.
Yes, and then you can discuss hormonal attenuation as a secondary permissive factor. The idea being that the anatomical space is there and the hormonal changes are what allow it to be utilized. It gives the reader a much clearer hierarchy.
I like that. It's a clean way to integrate the anatomy they measured. But what about the hormones themselves? The regainers still had pretty elevated GLP-1 compared to baseline.
That's a crucial, paradoxical finding. Regaining weight despite having high satiety hormones.
It suggests something else is going on.
It had to be counterregulation. Since they only measured GLP-1 and GIP, we'd strongly advocate for including other gut hormones in future studies. Specifically, ghrelin, the hunger hormone, and peptide YY.
To complete the picture.
To complete the hormonal picture, yes. It would let researchers test if this paradoxical regain is being driven by a surge in hunger signals that are simply overpowering the satiety signals. It puts the behavior back into a physiological context.
That's a fantastic point. And looking at future studies brings us to our last critique, which is about the methodology itself.
Right, the meal stimulus.
Exactly. The protocol was to measure hormones annually after a fixed 300 kilocalories standardized liquid meal. Ensure Plus.
And that standardization is good in theory, but over 5 years, it becomes a problem.
A double-edged sword.
It is. Utilizing a fixed calorie meal over 5 years in a group that's losing a massive amount of weight risks introducing a methodological bias that could artificially influence the results.
Because the relative stimulus changes. The average patient weight dropped from around 130 kilos to 90 kilos.
Think about it. That 300 kilocal meal is a dramatically different challenge to the body at year 1 versus year 5.
It's a much smaller caloric load proportionally for the lighter patient later on.
That's it, exactly. So this apparent gradual attenuation of GLP-1 and GIP, well, it might not be true hormonal fatigue. It could just be that the trigger, the meal, was getting weaker and weaker relative to the patient's new metabolism.
So the decline in the signal could be an artifact of the method?
It could be, in part, and it confounds the interpretation. If the stimulus intensity is changing, you can't confidently blame the reduced response only on physiology.
So what's the suggestion?
The authors need to acknowledge this limitation much more directly in the discussion, and then, for future work, propose a new standard for this kind of measurement.
What would that look like?
For a concrete methodological refinement, future studies should standardize the caloric load relative to the patient's current body mass.
So X calories per kilogram of body weight.
Or as a percentage of their resting energy expenditure. Something that ensures a physiologically consistent stimulus every single time, which is critical when you're tracking responses over years of such drastic change.
And what can they do with the data they already have?
They can get more out of it. We'd suggest better data integration. They touch on this, but it needs to be a formal part of the analysis. Calculate the area under the curve, the AUC, for the GLP-1 and GIP responses.
Right, instead of just looking at the peak at 30 or 60 minutes.
Because the AUC gives you a single integrated measure of the total hormonal exposure over that whole 2-hour window.
It's more robust.
Much more robust. It's less sensitive to small shifts in gastric emptying or gut motility, which can change the timing of the peak. By using the AUC, they create a better metric for long-term comparison against weight, even with the fixed meal limitation.
That's a really sharp point. That level of methodological detail is just essential for a study that's ambitious. This has been a really insightful critique.
Of some truly exceptional material.
Okay, so to summarize the main actionable points for the author. First, you need to bolster the statistical foundation for those predictive hormonal claims.
Either by reframing the conclusion to match the exploratory data, or better yet, by running an exploratory survival analysis, like a Cox model.
Second, integrate that behavioral and psychological context. Model the gastric volume as the primary anatomical driver, and bring in counter-regulatory hormones like ghrelin to complete the physiological picture.
Give the reader that holistic etiology of weight regain.
And finally, refine the meal stimulus protocol for future work. Acknowledge the fixed load limitation, and for the current data, really lean on the area under the curve calculations for more robust analysis.
If you implement these high-level suggestions, you'll really elevate the rigor and the clarity of the findings. The impact will finally match the strength of the data.
And we absolutely invite you to submit the revised material back to us for another look.
We'd love to see it.
This critique was based on the brilliant review by Dr. Reza Lankarani, who is an editorial board member of the Genesis Journal of Surgery and Medicine. To access additional details, please refer to the Surgical Pioneering podcast series application. You can find that at surgicalpioneer.codax.me.
Thanks for joining us.
Thank you for joining us on The Critique.